Right. Good afternoon, everyone who has joined the webinar today. Our webinar from FIP this afternoon is a Mpox update session, what pharmacists should know. Next slide, please. My name is Jocelyn Chaibva, President of the African Pharmaceutical Forum, and I'll be moderating this presentation this afternoon. A few announcements before we start. First of all, the webinar is being recorded and is live streamed via YouTube as well. The recording will be available on our website, www.events.fip.org. That's the FIP website. During the presentation, you may ask questions using the question box, which is provided, the Q&A box on the screen, at the bottom of the screen. You are also welcome to provide feedback on this webinar at a webinar@fip.org. We want your feedback so that we can improve, and even any other topics you might be interested in us sharing as the pharmaceutical fraternity. I also would want to invite all those of you who are not members to become a member, individual members of FIP, and the information is available at www.fip.org/membership/registration. So you can become an individual member of FIP. I look forward to us sharing this friendship. So this afternoon, the Mpox session is what pharmacists should know. And we've got two presenters this afternoon. Professor Wolfgang Preiser, who is from South Africa, and Dr. Philip Mukumbai is from DRC. The presentation from Prof. Preiser is a pre-recorded presentation, which will then be followed by the live presentation from Dr. Mukumbai. So the objective of this webinar, what we expect the attendees to learn, is about the pathophysiology, symptoms, and disease burden of Mpox, which we used to call monkeypox, but it's a Mpox, then existing vaccines and their efficacy in mitigating disease progression, the relationship between the current and previous outbreaks of Mpox, and the available treatment options, and as pharmacists, what is our role? The role of pharmacists in promoting awareness and preventing disease progression. We have a role to play in the progression of various diseases, and Mpox is not an exception. So it's important for us to share this information. So I've just done the introduction, and then we want you to understand more about Mpox, causal agents, the disease burden, pathophysiology, and symptoms will be done by Prof. Wolfgang Preiser, and it's a pre-recorded presentation. This will be followed by a second live presentation from Dr. Philip Mukumbai from DRC. It's on Mpox, patient support, and other pharmacist-driven interventions. And then Q&A, and then we'll wrap up. This session will take 1 hour. So, when we look at Mpox, it is a medical emergency and has been declared as such. The WHO Director General declared Mpox outbreak a public health emergency of international concern because the disease can spread across borders. So let's also be watching out in our different countries what is happening, whether we've got the disease being reported and even the cases which have not been reported. And vaccines have been distributed to various countries. 9 African countries have received the vaccine. And there are also plans to get the vaccine to other countries. So there's been a joint press release from Africa CDC, CEPI, Gavi, UNICEF, and WHO. More information is available on the website on what is happening. Let's keep ourselves updated in what is happening in our different countries. Unfortunately, the disease, there's no borders. It crosses borders just like that. So, as pharmacists, can I have the next slide, please? We've got a role to play in the prevention of the disease states. And we work together with other healthcare professionals to ensure that we control the spread of the disease. As such, you'll find that from WHO and from FIP, we've got a joint statement on dealing with national emergencies or international emergencies of this nature and of this magnitude. So it is important for us to check on our website as FIP in terms of prevention of a spread of these diseases, and also in our different countries on our national policies in this regard. So she's just fixing our slide, which are sharing on that, what the statement from FIP is about with regards to prevention of disease in the different countries as national emergencies. Okay. So we're saying FIP joint statement on pandemic prevention and preparedness in cases of disaster. So equitable terms on access and benefit sharing to ensuring outbreak preparedness. So the emphasis is quick access to pathogen samples, which help the healthcare workers, and it helps to accelerate response times and mitigate the impact of future pandemics, thereby lessening the strain on healthcare workers. We also want to ensure fair and equitable distribution of the vaccines, diagnostics, and treatments during pandemic, which will reduce infection rates and caseloads and ease the burden on healthcare workers globally. So there's a joint statement from FIP in this regard. So all healthcare professionals were invited to do our part in preventing and be prepared always to prevent worsening of the situation. Our next presenter is Professor Wolfgang Preiser. He's the head of division of medical virology at Stellenbosch University and National Health Laboratory Services, Tygerberg in South Africa. He has given us a recorded presentation because he's not available to talk to us physically today, but he did make an effort to give us this presentation. He's well experienced in virology, and he wants us to share his presentation on understanding Mpox, causal agents, disease burden, pathophysiology, and the symptoms of the disease. Can you please play the recording for us, please? Thank you.
Good day. My name is Wolfgang Preiser, and it's my great pleasure to try and give you a brief overview of Mpox, the agent that causes it, its epidemiology, and a little bit of the clinical symptoms. The head of the Division of Medical Virology at the Faculty of Medicine and Health Sciences of University of Stellenbosch, and also head a large diagnostic laboratory as part of the South African National Health Laboratory Service, or NHLS. And we are on the top floor of the front building, the tall building, and you see in the background iconic Table Mountain in Cape Town, South Africa. Is a member of the genus orthopox viruses, and it is as such closely related to variola, cowpox and vaccinia viruses. Now, variola virus is the one that caused smallpox, and vaccinia is the vaccine virus against smallpox. Monkeypox virus was first detected in captive monkeys in 1958, and this is where the name comes from, which is a misnomer. The first human case was identified in 1970 in what is now the Democratic Republic of the Congo, and this was in a child that had rash, vesicles, small vesicles appearing that look similar to the rash caused by smallpox virus, but is also easily confused with the chickenpox rash. Monkeypox virus is a zoonosis. The source are small mammals in the African rainforest areas, and for a long time there has only been limited human-to-human transmission. Importantly, vaccination against smallpox induces immunity also against monkeypox virus, the reason being that these viruses are so closely related. Let's do a quick dive into history. Smallpox has been a killer of humankind for thousands of years. You see on the left an Egyptian mummy that bears the hallmarks of having survived smallpox, and on the right is a depiction of what smallpox did when it was introduced into the Americas by the colonialists. It was mayhem. We haven't known infectious agents for such a long time, and before all sorts of theories circulated, but still in some places good records were kept of what people had and what people died from. And this is an example from London. You see on the left hand side of this graph that up to 1 in 13 people inhabiting London would have died from smallpox and its complications. And then from around 1800 onwards, after the vaccine developed by Edward Jenner became available, how this morbidity and mortality due to smallpox declined. The smallpox vaccination proved so successful that it allowed the global eradication of smallpox as a human disease. To this day, it remains the only human infectious disease ever to be eradicated. It was during the final decade of the smallpox eradication campaign, which was a major global effort, that monkeypox, now called Mpox, was found in human beings, and there was surveillance ongoing. And you see very small numbers in the tropical rainforest areas of Africa. There is the so-called Clade 1 monkeypox virus that occurs in the Congo Basin countries, and the Clade 2 monkeypox virus along the West African coast. The next decade, the 1980s, not much changes. Same in the 1990s, relatively low numbers, only confined to the areas where we know the virus is endemic due to its presence in the small mammal host species. Then in the 2000s, surprise, for the first time, monkeypox virus was found outside the African continent, namely in the United States, and the story is one of human grade and poor practices. Small mammals were imported for the pet trade, were then kept together with the North American native prairie dogs. Unknown at the time, the imported mammals carried monkeypox virus, and the prairie dogs were susceptible. They became infected. They were sold off to the unsuspecting public, and 47 cases occurred. Fortunately, all mild. And subsequently, this led to the recognition of the risk that such trade poses, and at least the importation of the species in question has been banned. So from 2010 to 19, is everything back to normal? You see here the numbers again in Africa, in the Congo Basin, and then along the West African coast, mostly very small numbers, and a splattering of imports into other continents, usually the traveler themselves, and very occasionally in the UK, ongoing transmission to very close family members, but not spreading further. So is everything fine and don't we have to worry? Are we still dealing with the same scenario, which is people expose themselves to the small mammal hosts in bush meat markets, or when out hunting and collecting and gathering and preparing food? become infected, may pass the virus on to close contacts, but it doesn't go any further. Unfortunately, not quite so. It was first noticed in 2017 in Nigeria. This article appeared earlier this year only, a report on what happened then, and this makes a fascinating read, that something had changed. Suddenly, it was found that cases were occurring in ever greater numbers, and people had not been exposed to these small mammal hosts, but only to other human beings. And it was also found that oftentimes the exposure probably involved sexual contact. And this phenomenon did not remain confined to Nigeria. During 2022, a massive global outbreak occurred. Mpox cases were being recognized in numerous countries around the world, and the total to date since beginning of 2022 stands at almost 110,000 lab-confirmed Mpox cases, including 236 deaths. You see that the majority of the countries affected were not from the previously known endemic zones of Mpox. So what had happened? Immunological investigation supported by genetic evidence found that a newly recognized virus clade was involved, which was called 2B, related to but different from the previously known West African clade. And importantly, that we were now dealing with sustained human-to-human transmission, long chains of transmission within the human population, i.e. it was no longer a zoonosis, no longer the need to have exposure to the small mammal hosts. Importantly, also it was found that this virus bears the signature that suggests that it has been circulating in the human population for prolonged periods. In order to do so, it has to overcome certain immune mechanisms that we have that help us defend ourselves, and that leads to the accumulation of certain mutations. And calculating how fast that could have happened, it was suggested that this virus strain that went global in 2022 had been circulating exclusively amongst human beings since 2016. And this is the reason, together with the rapid increase in cases and this enormous spread across the globe, that WHO declared the Mpox outbreak a public health emergency of international concern in July 2022. The world experienced an extremely steep surge of cases of infection. You see how fast numbers are rising there, particularly in the European and American regions of the WHO, so outside the continent where the virus originated from, which is Africa. But that at the same time, there was an almost equally rapid decline after a few months. And the reasons have been investigated, and this decline in the case numbers has been ascribed to behavioral changes. People realized what posed the risk for getting Mpox, and also vaccination becoming available. You might remember that I mentioned that vaccination against smallpox also induces immunity against Mpox virus, and indeed, fortunately, there had been stockpiles of smallpox virus prepared for the eventuality of biowarfare or bioterrorism attacks, and those could be made available to protect the at-risk populations, largely MSM, men having sex with men, by offering vaccination, which also protects against infection with the monkeypox virus. So is everything good again? Sadly, one cannot say that. Even though the global outbreak subsided rapidly, it is still ongoing at much lower case numbers. But in addition, there is a new problem, and that new problem has a different epicenter in Africa, in Eastern DRC. And it consists of another rapid surge in case numbers of Mpox, of infection with the monkeypox virus. On studying the virus involved, it was found to be yet another previously unknown clade, a derivative of the Congo Basin one, now termed clade 1b, and it also bears the 3 signature. That means it suggests that this virus again has been circulating exclusively amongst human beings for prolonged periods. In the case of MPXV clade 1b, it's estimated that since the second half of 2023, it has been transmitted from human to human. And case numbers are surging. One mode of transmission is sexual transmission in the context of oftentimes very unregulated mining activities, like on this picture here, where there are then also is a lot of prostitution, a lot of transport happening, and along these routes the virus has been spreading. These graphs show case numbers starting with the Democratic Republic of the Congo, and please note that the numbers are very different here. Congo, Burundi, Rwanda, Uganda and Kenya. So there has been spread of this particular viral clade to neighboring countries, and on a few occasions also to countries further afield in Asia and in Europe. And to my knowledge, there has so far been only one report of ongoing transmission of that virus in a non-African country, but that is of course something that needs to be closely observed. What this graph also shows is in red the total suspected cases and in blue the confirmed cases. That means cases that are suspected and are then tested and found to be truly Mpox. And this is very concerning because it suggests that in the most affected areas there is not sufficient testing capacity, so we are actually flying blind. We don't really know who has Mpox, who may have something different which may be harmless, and also there is probably under ascertainment of cases, so a big challenge to get on top of this. And because of these very worrying features, WHO once again declared a public health emergency of international concern in mid-August this year, which is ongoing. So in Africa, we are currently dealing with 3 different patterns of Mpox, and each of them is associated with certain viral clades. So firstly, there is the endemic clades 1A and 2A. Those are usually acquired from a zoonotic source with limited ongoing transmission human to human, and that's a scenario that we've encountered for many decades. Then there is the global outbreak, which is clade 2B. It is ongoing here in South Africa, where I am speaking from. We had over 20 cases this year, including 3 deaths, which is worrying, which is a much higher death rate than observed internationally. And this occurred in patients with advanced immunodeficiency who were not on treatment. And then finally, we have the newly recognized threat through clade 1b spreading from eastern DRC into neighboring countries and further afield. Many of its characteristics are not fully known yet, but it is definitely a big concern. I don't want you to look at the details, but this is from a recent WHO Africa report on DRC alone, and you see that from flooding to a humanitarian crisis due to civil unrest and warfare, they are dealing with outbreaks of cholera, measles, Mpox, and 2 different strains of poliomyelitis. And one could understand if the local population would not see Mpox currently as their biggest concern. This is a difficult area to work in. So what we need now is a really massive deployment of medical and scientific staff to start a good humanitarian response and also collect all the evidence that we still don't have about this. We need more diagnostic testing. Hopefully many of the cases that are suspected may have something else, but we don't know. We also need to know what it is, and we need to know who has it, because only then can we isolate cases, we can monitor close contacts, and we can, now with vaccines being made available, we can try and perform ring vaccination, which means vaccinate people who have been in contact and contacts of contacts in order to prevent the ongoing spread of the virus. So there are many challenges that need to be tackled. Diagnostic tests are being developed and are being licensed by WHO. The problem is that there isn't really a rapid antigen test that could be used at point of care. And these PCR-based assays require a minimum set of facilities and also operator training, which are difficult to achieve in many places. And I would like to highlight some lessons that I hope should be learned from Mpox. So firstly, there are pathogens that we've known for a long time, and we think we know them, but they may suddenly, apparently, take on new characteristics and become bigger problems than before. In the case of Mpox, we are relatively lucky because there has been investment into vaccines and antiviral drugs, but not against Mpox in the first place, but against biowarfare and bioterrorism or using smallpox or related viruses. And these developments and stockpiles now benefit the Mpox response. One also sees very clearly that only when things get out of hand will there be funding for research, and research will produce insights. That is evidenced by the number of publications. It's a massive burst now that there are more eyes on Mpox. And we also need to worry about new animal reservoirs. The prairie dog incident showed that there may be animals in different continents that could be susceptible, and if we are not careful, we might establish new reservoirs and have then an ongoing problem of zoonotic transmission, something to keep in mind. With this, I would like to thank you very much for your attention, and unfortunately, I'm not there in person, so I will not be able to answer any questions. Thank you very much. Bye-bye.
Thank you very much to Dr. Wolfgang for a very enlightening presentation. I've seen some questions in our box, in the Q&A box. If we don't have responses coming in from the people here, we'll then get them to him to answer some of those questions, and so that we get the correct responses, which will address our concerns, and they will be shared. Thank you so much for the presentation to Professor Preiser. So our next presenter is Dr. Philip Mukumbai. He's a commercialization officer, pharmacovigilance specialist from Kinshasa, DRC. And Dr. Mukumbai is skilled pharmacovigilance expert and commercialization officer with extensive experience in clinical research, pharmacovigilance, and public health. Currently, he's working with the PATH in DRC. He has over a decade of experience advancing healthcare initiatives that enhance access to safe medicines and medical products, particularly in resource-limited settings. Throughout his career, Philip has contributed to strengthening pharmaceutical regulations, conducting market intelligence analysis, and supporting manufacturers in implementing global access principles. He has played a pivotal role in managing clinical trials, including those for infectious diseases, such as Ebola virus, COVID-19, Mpox, and malaria. Philip is affiliated to the Department of Pharmacology and Therapeutics at the University of Kinshasa as a research assistant. In his position, his main research area is medication safety during pregnancy. So he has contributed a lot in improving drug safety and enhancing access to essential medicines and ensuring the successful implementation of clinical trials in DRC. His work in pharmacovigilance has strengthened national drug safety framework, allowing the better detection of adverse drug reactions and improved patient outcomes. As a commercialization officer, Philip continues to shape pharmaceutical markets for life-saving medicines with a focus on postpartum hemorrhage treatments and other critical health interventions. Dr. Mukumbai, welcome, and you can take over and make your presentation. Thank you so much.
Thank you. Thank you very much. Thank you, everyone. I'm very happy to be here and share a few knowledge what pharmacists should know about Mpox virus diseases. Slide. Yeah, so the first presenter has explained in details some of the things I have included here. The first part of my presentation, I will just emphasize on some key points that we should know. And as the professor said before, Mpox virus disease is a zoonotic disease caused by Mpox virus, which is actually a orthopox virus. So when you look at the scheme here in the right, you will see that we have a lot of viruses in this family that causes infections in humans, such as vaccinia virus, Mpox virus, which actually circulates among humans, but also have they can also cause recurrent infections. However, cowpox virus, buffalo pox virus, and camel pox virus circulate only in animals, and also the variola virus, which is actually eradicated. Slides. Yeah, so the first case was identified in DRC in 1970. And so two main clades are circulating as in endemic pattern in 10 African countries. So we have the clade 1, which circulates in the Congo Basin, and the clade 2, which circulates in West Africa. Slide. So in 2003, this is the first time the Mpox virus case was identified outside of its endemic regions, so outside of Africa. And the first case was identified in US, where 78 people were infected following importation of infected animals from Africa. And in 2022, the UK confirmed case of Mpox in individual returning from Nigeria. And on this year, an outbreak was caused by this virus. Up to 14,000 Mpox cases were identified in 72 countries around the world. And the WHO declared Mpox virus disease as a public health emergency of internal concern. So according to the CDC, the US CDC, the majority of Mpox cases were identified in high-risk population of gay, bisexual, and other men who have sex with men. So this is the first time the transmission, the sexual transmission was reported. Next slide. And in 2023, you see, so this is a case of DRC in 2023. Around 14,000 cases of Mpox virus disease were reported, and case fatality rate around 4%. And if you can see in the map here, in DRC, the endemic regions are almost the north and east, the western. And for the first time, the virus spread to the eastern part. This is because of the identification of a new mutant, a new variant of clade 1 virus, which is actually circulating in eastern of DRC and also in other neighboring countries. Next slide. So in Africa, up from January to September 2024, around 25,000 suspected cases were identified, and the confirmed cases were around 5,000. And these are the countries where the virus circulates actually. Next slide. Yeah, so now there is hypothesis around the re-emergence of Mpox virus. So some of them are the highly mobile and mobile populations. You know, we live in the time where people are traveling a lot, coming from remote area to reach bigger towns. So this might be the reason why the virus is re-emerging, and also the animal transport, the rainforest exploitation. And the major hypothesis here is the cessation of smallpox vaccination. So actually it is reported that smallpox vaccination cross-protect against the Mpox virus. So people who were vaccinated, who received smallpox vaccines, are less likely to be infected by the Mpox virus. So as the smallpox is eradicated and the vaccination is ended, so that's why the Mpox virus might be re-emerging. Next slide. Yeah, so this is the transmission pattern. There is a cycle of transmission in the animal world where rodents infect monkeys and so on. And there is a spillover from monkeys to human and from rodents to human. And human to human transmission results from close contact with respiratory secretions, with skin lesions, and also from sexual transmission. So this is the recent findings of the mode of transmission of this virus. Next slide. Yeah, so this is how the clinical presentation looks like. So when the person is exposed to the virus, so there is a time period of 7 to 17 days of incubation. And after that is the prodrome. During the prodrome period, someone can experience fever, headache, fatigue, and lymphadenopathy. So and still these symptoms are general. You cannot say I have Mpox disease based on this infection. And after that, around 14 days to 28 days, that's where the rash starts appearing on the skin. So it will start with the macules, which will evolve to papules and up to the crash scrub. So after this period, someone can resolve. So there is a resolution in many cases, but also it can lead to some complication such as secondary bacterial infection, pulmonary involvement, severe dehydration, diarrhea, vomiting, and so on. Slide. Yeah, now let's talk of prevention. So the most efficient way to prevent Mpox disease is to avoid contact with infected animals, and also to have good hygiene when you are in you live in the endemic area or in the outbreak area. You should wear protecting clothing, and isolation of suspected cases or identified cases of Mpox viruses. So another way is vaccination. Study has proved that the vaccine can offer protection against Mpox infection. So actually there is 3 vaccines, first generation, second generation, and the Genius is the one is currently being spread for vaccinating suspected cases and people in contact with Mpox virus cases. Slide. Now for treatment, so the treatment is actually limited to treating symptoms and secondary bacteria infections, and also giving supportive cares for any complications. So there is a couple of treatments of medicine that have been identified as having activity on this virus, but actually this first one, tecovirimat, was studied in a randomized control trial to see if it can be used, it can prevent, it can treat actually the Mpox virus diseases, but the result, the study failed to show the good results when compared to the standard of care. So this drug is not effective in treating Mpox virus. Next slide. Yeah, so the Africa CDC has developed a preparedness and response plan, which contain 10 pillars. So the first is the coordination and leadership. So as you might hear from the previous presentation, so we need a code to respond to the outbreak. We need multidisciplinary approach, and also involving organizations that are able to coordinate the response, and also the risk communication and community engagement. This is where, as pharmacists, we might have a key role to play in communicating the risk to the population, and showing them what they can do to prevent from these diseases. So other pillars are surveillance, laboratory capacity, the case management, infection control and prevention, research and innovation, operational support and logistic, and also continuity of essential service. So now let's see what pharmacists can do, or what can pharmacists bring, what role pharmacists can play in raising awareness and education. So as pharmacists, we might educate the population in recognizing Mpox symptoms and how the transmission is performed, and also we might correct misinformation and reduce stigma. So now, because most of sexual transmissions happens in what can I say, in commercial sex workers, and also men having sex with men. So this might create some stigmation, and might also create some disinformation. So anyone who has Mpox disease might be considered as that kind of person. So when we as pharmacists, we need to break this myth in educating the population, in giving the right information to the population. And also we need to inform them on the prevention measure in hygiene, avoiding close contact, and also isolation. And when someone is having symptoms which are not identified, so we might need to ask him to search for care, for timely care, in order to diagnose and giving proper treatment. Next slide. Yeah, and also as pharmacists, we might play a key role in counseling the populations on the vaccination. So we might identify the high-risk population and advise them to seek for high-risk population. Here are people living in outbreak regions, and also people living in close contact with suspected cases, or people infected with Mpox virus diseases. So we might inform these population, identify this population, and also advise them to seek for vaccination in order to prevent the disease. And for people who are already infected, so we might encourage them to be adherent to the treatment, and to help them how to manage the adverse drug reactions. Yeah, thank you for your attention. And
thank you so much. Sorry. Thank you so much, Dr. Philip, for your very eye-opening presentation, which has actually opened a lot of questions. Maybe I can just, if you have got one or two questions which you can respond to from the Q&A box. There are so many questions, but I think some of them we may not be able to respond to them in this presentation. Maybe I'll just pick a few questions which you can, which could be of interest. What are the challenges in treatment of Mpox in pediatrics population and in pregnancy, considering that you are doing that as part of your work, Dr.
yeah,
Philip?
so
just a minute,
yeah.
Just short questions, short answers. Thank you.
Yeah, sure. Yeah, thank you for Aslam for the question. So actually, so I will give a case of an outbreak, like an endemic situation where I was involved. So in that region, most of cases were pediatric. So not only the pediatric population will come not only with Mpox disease, but also with other comorbidities such as malnutrition, and so it's like they will come with a syndrome that the clinicians must take care. So the challenges here are, one, you need to deal not only with the Mpox symptoms, but also with the malnutrition. Some will come with eye problems, since one of the complications of the Mpox is the attempt to the eye. So so when pediatric population have these diseases, we need to consider all other aspects of the health status, not only on the Mpox diseases. So for pregnancy women, so I don't have enough information to give now. So maybe it will follow with when we answer to any other questions remaining.
Yeah. So because there are so many people are very much interested in this topic, from what I'm seeing here, pharmacists have got a great responsibility to create awareness to the community. How does the pharmacist make aware about the disease? And when people see animals with how do you know that the animal has got a Mpox? So these are just some of the important questions when you are looking at prevention, so that people will understand more about the disease. So I would actually advise that you take these questions, which are reading out, and then they will get a response, the written responses, which will be shared on our website as FIP, because there are so many interesting topics which have been raised from the questions.
Yeah.
And then if necessary, we might have to think of having another webinar with a similar topic. Maybe just as I was looking through, what can pharmacists do? And when they get in touch or in contact with patients who walk into the pharmacy, like in a community pharmacy setting, and they are likely going to have to be carrying the disease, the same situation would also apply to medical practitioners in this setting, either in a private surgery or even in a clinic. So these are some of the things which we need to address to prevent spread of the disease, and be prepared, which actually highlights the issue of preparedness. And as alluded to earlier on, the disease has been there, and the testing, because it was probably in one country, and the information, the research, because as alluded to by the first presenter, people sometimes don't focus when it's in the poor countries or where they're resource limited settings. But now when it spreads the world over and becomes an international threat, you are likely going to get a more positive response, vaccines coming up, and people addressing the issue of the disease states which are coming up. Unfortunately, I don't have much time for us to hear responses from our presenters, because we've got a few minutes left before we wind off. So, but I just want to thank everyone for attending and listening to some of the issues. And I would want to challenge us as pharmacists in our different countries to take this up and educate one another, to continue on continuous professional development on this topic. I was just looking at Zimbabwe. It has not been a serious problem initially, but there are already reports which have been reported, 2 cases in the past month, or rather in this month. And South Africa has also reported some cases of the Mpox infection. So every one of us is at risk. The risk is high, as alluded to by the presenters. Thank you very much to the 2 presenters we've had this afternoon. Can I have the next slide, please, as we wind off? So as I just alluded to earlier on, we all need to get back to our desks and do the right thing so that we address this problem, which is of an international magnitude. It spreads quite easily with the amount of, because the world is now a global village. So let's be on the watch out. So you must check all FIP digital events here. That is on www.events.fip.org. We've got a lot of webinars, which are educators, which tries to bring us on par with what is happening in the pharma sphere. So let's always check on that website. You'll see what else is coming. And before I go, we're just in Cape Town this year for our conference. That is the FIP World Congress. So for the next year, it will be in Copenhagen, Denmark, from 31 August to 3 September 2025. And the theme is Pharmacy Forward, Performance, Collaboration, and Health Transformation. That's the theme for our conference in Copenhagen. So let's be seen there. Let's make preparations. Time is now to start preparing and get ready. Let's not wait for it like it's an emergency. This one is where we get to prepare so that we deal with the travel issues, visas, and everything. Let's get ready to be in Denmark in August 2025. Next slide. Our final slide. Well, I just want to thank everyone for that. As I was talking about the slide, the 2025, there are sub-themes which have been highlighted there. We'll share more about that. If you go on the website, FIP website, this presentation has been recorded and it's making it sustainable, making the system work, and making it personal. So it's about us and other healthcare professionals working together for best outcomes. So the other dates to remember, important dates about the conference in Copenhagen. 17 March 2025 is deadline for submission of abstracts. So be a presenter, share what you know. And then 2 June 2025 is early registration fee deadline. After the 2nd of June, the registration fees go up. And then on the 11th of August, the second registration deadline, and then we have higher fees. So let's be there. Let's register early. Other than registration, let's also make abstracts. Let's make a plan so that we do present and meet in Copenhagen in 2025. Thank you so much. Thank you, everyone, for attending this webinar. If you have got any questions or comments, you can send them through to our website. Thank you.